Good morning, everyone. Welcome to Wednesday morning rounds. Today we have Dr. Evan Martow, one of our second-year Electrophysiology Fellows. Evan did his medical degree at McGill and then went on to the University of Alberta in Edmonton to pursue his internal medicine and cardiology training. And he's joined us to complete his EP fellowship. So we welcome him today. He's going to be talking about atrial fibrillation and ablation. So we'll turn the presentation over to Evan.
Thank you, Dr. Stadnik. So, title of my presentation today is Atrial Fibrillation Ablation, Opportunity for More or All in Vain. Sort of the roadmap for the talk is I'll do sort of a quick overview of atrial fibrillation, including some of the modern terminology and classifications from the most recent CCS guidelines, and go over a bit of the pathophysiology and relevant anatomy, discuss the evolution of ablation, including some of the new techniques and technologies that have come through over time. We'll do a bit of a focused evidence review around some of these techniques that have come out, as well as a brief discussion of potential future directions. And then I wanted to spend a chunk of time towards the end talking about a local quality improvement project that Dr. Golian and I have been working on, sort of dubbed the Atrial Fibrillation Bundle. So atrial fibrillation, as we all know, relates to impaired atrial function as a result of disordered or chaotic appearing electrical activation. This can have significant hemodynamic consequences, including the loss of effective atrial kick, tachycardia resulting in cardiomyopathy, and most critically, a predisposition to embolic stroke risk. Of course, we're all now familiar with the CHA-65 score, which is the Canadian risk stratification system for stroke risk in typical non-valvular atrial fibrillation. Atrial fibrillation is a growing problem. It's estimated that about 1 to 2% of the general population has atrial fibrillation in some form, although this may represent an underestimation, given that we have lots of evidence that the more that we look for atrial fibrillation, the more we actually find. We also know that atrial fibrillation incidence and prevalence increases with age as well, reaching as high as 12% in those greater than 80 years of age. The impact is significant, including increased mortality, stroke risk, and significant impacts on quality of life. The CCS classification includes a few different classification systems. One is based on clinical pattern, which is dividing a division based on chronology, and as well as one sort of based on philosophy. Permanent atrial fibrillation generally refers to long-standing persistent atrial fibrillation in which we've no longer pursued a rhythm control strategy. There is no plan to restore sinus rhythm. Interestingly, though, a twerk of that terminology is that, or a perk of that terminology is that a patient diagnosed with permanent atrial fibrillation or labeled with permanent atrial fibrillation may actually be in sinus rhythm at any given moment. If multiple patterns are present, then it's really the predominant pattern that's selected. The graphic on the upper right of the screen demonstrates the relative importance of triggers as opposed to substrate in the development of each of these phenotypes of atrial fibrillation. As you can see, triggers of atrial fibrillation play a more prominent role in paroxysmal atrial fibrillation, whereas as we progress over to persistent and into permanent atrial fibrillation, it's more the substrate that's playing a role in maintaining atrial fibrillation. And as you can see, they've delineated 3 different groups: non-modifiable substrate, modifiable substrate, and then atrial fibrillation-induced substrate. And this relates to the concept of atrial fibrillation begetting atrial fibrillation. This will have relevance when we talk a little bit further on about some of the newer trials that are suggesting that earlier intervention in rhythm control for atrial fibrillation may have significant benefits down the line as we can minimize this AF-induced substrate. Another way that atrial fibrillation is classified is based off of pathophysiologic pattern. So this is primary and secondary. So primary indicating an established pathologic process that's contributing to atrial fibrillation development, whereas secondary refers to either a reversible or a provoked stimulus. Reversible refers to atrial fibrillation that's deemed to be a result of solely an acute insult. So for example, thyrotoxicosis or alcohol intoxication or other toxins, whereas provoked is felt to represent an acute insult that reveals a predisposition to underlying substrate. And this would be relevant because, of course, patients with provoked atrial fibrillation are going to be at greater risk of recurrent atrial fibrillation, whereas those who have reversible AF may not actually have AF in the future, so long as that a single acute insult is dealt with. There's also been a bit of evolution in terms of the distinguishment between valvular and non-valvular atrial fibrillation. It's now been simplified such that valvular atrial fibrillation is atrial fibrillation in the context of any mechanical heart valve and moderate to severe mitral stenosis of any source. This is relevant because, of course, the CHAD65 risk score applies in the context of non-valvular atrial fibrillation and not valvular atrial fibrillation. Another important subgroup to mention is hypertrophic cardiomyopathy, in which we cannot apply the CHAD65 risk score as they have a very high risk of embolic stroke, and so all patients in that group ought to be anticoagulated. Finally, another classification system described in the newest CCS guidelines is the symptom pattern. This hasn't really changed since it was first proposed, but the CCS-SAF score mimics many other similar scores such as the NYHA score and CCS angina score, except that sort of in terms of the distinguishing between minimal and mild symptoms, really, and with class 0, of course, representing 0 symptoms. Our evolution in terms of understanding atrial fibrillation has a long history. An irregular pulse in the, or an irregularly irregular pulse in the context of mitral stenosis was first described in the 1800s, actually. In terms of the actual mechanisms of arrhythmia and relatedness to atrial fibrillation, that came up more in the early and mid 20th century. Early treatments for atrial fibrillation coming up in the 70s and 80s focused on controlling the rapid rate of atrial fibrillation with either surgical or catheter-based ablation of the conduction system. Subsequently, the Mays procedure was conceived of and implemented, and this essentially involved segmenting the atria to isolate portions or create a single avenue of activation in order to try to minimize the opportunity for atrial fibrillation substrate to contribute to the development of atrial fibrillation. Over time, this procedure has been refined in order to include a more conservative lesion set, as the success of the procedure was limited as a result of sequelae from very extensive lesion sets, and that could include problems with the conduction system, problems with sinus node activity, as well as development of macro reentrant circuits. A real breakthrough in terms of the management for atrial fibrillation came with work from Dr. Hasseguer in France, in which he identified atrial fibrillation triggers within the pulmonary veins. The result, in this work, he also performed ablation with a focal ablation of those triggers and showed a significant reduction in the burden of atrial fibrillation following this. And this really led to an explosion in terms of research and interest into triggers for atrial fibrillation, and then following that, management strategies as well. The important anatomic correlates to this is the demonstration of myocardial sleeves that surround the pulmonary veins on the adventitial side. These myocardial sleeves are a bit disorganized in terms of their morphology, and as a result, this provides opportunities for re-entry, which could be one potential source of why the pulmonary veins are such an effective trigger for atrial fibrillation. Another potential avenue for the pulmonary veins being an important trigger is the evidence of conduction and pacemaker type cells that have been found within these myocardial sleeves. These could be a source for automatic ectopic activity, which could also be a trigger. This figure sort of demonstrates the coevolution of our understanding, both in terms of mechanisms and treatments for atrial fibrillation. One of the things that it emphasizes is how some of our strategies for targeting the pulmonary veins. Early on, we performed focal ablation targeting abnormal signals that could be seen within the veins. This had its limitations, both because it required ablation deeper within the vein, which could promote stenosis, and also because although we might ablate individual triggers that are identified at that time, triggers in other veins or other triggers within that same vein could then come out and still be a important contributing factor. As a result, isolation of the veins by performing ablation around the ostia of the veins became increasingly prevalent. In the early days, we found our best success really in the paroxysmal atrial fibrillation group, but found lower success rates in the persistent atrial fibrillation group. And this group has become a more intense area of focus to see how we can improve our outcomes with persistent atrial fibrillation. This also makes sense when we think back to that early diagram of the importance of atrial fibrillation triggers in paroxysmal atrial fibrillation, as opposed to substrate in the context of persistent atrial fibrillation. This is another diagram demonstrating some of the modern theories around atrial fibrillation initiation and maintenance. And really our understanding of atrial fibrillation has now moved into a territory where we focus separately on factors that initiate as well as factors that maintain atrial fibrillation. Each, of course, are critical to have atrial fibrillation. If either one of them, even if you have triggers of atrial fibrillation, if they're infrequent and there's no ability to maintain atrial fibrillation, then it would last only a very short duration before reverting back to sinus rhythm. And what's also come forward is this concept that I mentioned earlier, that atrial fibrillation begets atrial fibrillation. Structural changes as a result of multiple cellular mechanisms, including calcium overload and myocardial remodeling, can result in structural changes, which itself can promote substrate, which can act as either triggers or factors to maintain atrial fibrillation as well. So I've mentioned the challenge in dealing with persistent atrial fibrillation. The development of persistent atrial fibrillation as opposed to paroxysmal atrial fibrillation often indicates the development of a significant burden of substrate in order to facilitate the maintenance of atrial fibrillation over a long duration. Pulmonary vein isolation alone in paroxysmal atrial fibrillation has success rates that reach in the 70 to 90% range at 1 year, whereas persistent atrial fibrillation is not quite as impressive. We've had multiple trials looking at ways that we can achieve better outcomes than PVI alone in the context of persistent atrial fibrillation, but haven't really found a reliable strategy to achieve this in large randomized trials. The STAR-AF2 trial looked at 3 different strategies, PVI alone versus PVI plus lines in order to prevent macro reentry, and PVI plus scar ablation, and found similar results in each arm. The standard as a result has remained PVI with additional ablation being performed as part of research protocols. Our own locally run RCT, I say locally just in that we're the leaders on it, but it's of course a multi-center trial, is the COAST trial, in which we're looking at pulmonary vein isolation alone versus PVI plus tailored ablation of scar with specific strategies in order to try to limit the potential for macro reentry or problems as a result of the additional ablation being performed. So it would be important, of course, to also mention the other strategies. So I've been talking up to this point very much about the rhythm control strategies for atrial fibrillation, specifically ablation. Of course, there's also medical therapy that we have for rhythm control, most effectively being amiodarone. There are a couple of important trials that were done to look at rate control versus rhythm control strategies, specifically the AFFIRM and RACE trials. These found rate control to be non-inferior to rhythm control, but the focus really in those trials was rhythm control with medical therapy as opposed to ablation. Ablation didn't really play a prominent role. It only was third line option in the AFFIRM trial. And so the result of these studies was really that ablation ended up primarily playing an important role for symptom management. And the modern trials that have come up to that have demonstrated the effectiveness of ablation have really used antiarrhythmic therapy, antiarrhythmic medical therapy as the comparator. A couple of important ones in along this vein to mention were the CASTLE-AF and ATAC trials, which suggested a mortality and hospitalization benefit. A benefit in terms of mortality as well as hospitalization with ablation as opposed to medical antiarrhythmic therapy in a heart failure population with reduced ejection fraction. And the Cabana trial, which although it did not demonstrate mortality benefit or other hard cardiovascular outcome benefit as for ablation as compared to amiodarone, it did demonstrate a significant improvement in terms of quality of life. So we're still really waiting for large trials to demonstrate a benefit in terms of hard CV outcomes. One important aspect of the research into the area of effectiveness for atrial fibrillation treatments is a recent development in terms of a redefinition of what we consider to be success. Commonly used benchmarks for success in atrial fibrillation trials were freedom from atrial fibrillation or atrial tachycardia of greater than 30 seconds duration on monitoring. So as soon as you had one episode of atrial fibrillation lasting 30 seconds or longer on monitoring that's done, then that counted as sort of a failure of treatment in that arm. This has its limitations. As we've seen, the more that we look for atrial fibrillation, the more of it that we find. So if you aren't doing as extensive monitoring, then you may not find as much atrial fibrillation, and that could influence the results. A possible new gold standard has been emerging from a few trials that have been done recently, including the Circadose and early AF trials. These focused on, these trials both involved implantation of a loop recorder to have continuous monitoring of atrial fibrillation burden, both prior to ablation and following ablation. And they showed very dramatic decreases in the reduction in the burden of atrial fibrillation, approximately 99% burden reduction. They also showed using the previously defined, the previously used definitions for success. They showed that atrial fibrillation was not as successful if you use that definition. Important to note, though, that of course this would include asymptomatic episodes that may not be as clinically relevant from a patient perspective as well. The other important recent development in research in atrial fibrillation has been the demonstration of a potential benefit in terms of cardiovascular outcomes with earlier rhythm control. The recently published EAST-AF-NET4 trial looked at that and compared a early rhythm control strategy to usual care, which would be rate control and rhythm control only if symptomatic or if rate control was ineffective, and showed that the early rhythm control strategy was quite effective in terms of reducing these CV outcomes. So that has important potential clinical implications. In terms of the way that we can perform the pulmonary vein isolation, really the cornerstone of atrial fibrillation ablation, we have two main options in terms of cryoballoon ablation versus radiofrequency ablation. They each have their advantages and disadvantages. They've been directly compared in the Fire and Ice trial, which showed non-inferiority and really safety and efficacy of either option. There is still ongoing research looking into how we can be most effective in terms of performing these ablations. Studies like the Circa dose trial looked at different dosing options for cryo delivery. Research such as the CLOSE trial looked at a standardized approach to performance of pulmonary vein isolation. Here we recently finished recruitment for another randomized controlled trial called the AWARE trial, which looked at performing really a double layer of ablation around the pulmonary veins, looking to see if that can improve our rates of durable pulmonary vein isolation. A trial that's in development and probably in the near future will start enrollment is the AWARE-2 trial, which is going to be looking at different treatment modalities to try to see what we should be doing going forwards. It's also worth mentioning that the delivery of radiofrequency ablation has evolved over time, and high power short duration has come forward as an option to both improve the effectiveness of our ablation lesion set and improve the safety of it, as well as, of course, shorten the lesion duration. So a quick mention about what the guidelines actually say about the performance of atrial fibrillation ablation. It is recommended in patients who are symptomatic after an adequate trial of antiarrhythmic therapy, in whom a rhythm control strategy is desired. And there's this addition of a upfront first-line catheter ablation for relief of symptoms in selected populations. So that could include, for example, patients with significant heart failure, tachycardia-induced cardiomyopathy, or a very high burden of symptoms in whom you want to try to achieve the most effective rhythm control strategy up front. So what does this actually look like from within the EP lab? This is an example of a 3D electroanatomic map of the left atrium, in which we've got the pulmonary veins. On the left, we've got a posterior view, and on the right, a anterior view, and you can see our ablation lesion set encircling the pulmonary veins. I had to take the opportunity to include a video here of some of what we do in the EP lab as well. This is an example of a case of a patient with persistent atrial fibrillation who had previous pulmonary vein isolation and had recurrent atrial fibrillation. which was found to actually represent an atypical flutter. You can see they have a large area of the red indicates scar and the purple indicates normal voltages. So they have a large area of scar on the anterior wall here. The red around the pulmonary veins represents the previously performed isolation of the pulmonary veins, which had been durable and effective. We found that there was the arrows represent the direction of conduction. We found that there was a circuit around the mitral annulus, which was ablated, and then we also performed ablation across the anterior scar to prevent macro reentry. Yeah. So a couple of, so this is sort of the last slide talking about atrial fibrillation advancements. Some of the novel approaches that are being investigated, including some that we've talked about already, include selective scar ablation, trying to bring out non-pulmonary vein triggers at the time of atrial fibrillation ablation as well, and those who experience recurrence of atrial fibrillation despite isolation of the pulmonary veins. There's also research looking into what's been dubbed cardio-neuroablation, which is the ablation of ganglionated plexi within the atria that can mediate vagal activity and can act as a both a trigger and a maintainer of atrial fibrillation in patients with recurrent AFib. Renal denervation is also experiencing a potential resurrection, as there's been some demonstration of reduction in atrial fibrillation burden, as well as improvement in hypertension in patients with both atrial fibrillation and resistant hypertension. And this is conceived to be effective through reduction in sympathetic tone. And then another area is the ablation of the ligament of Marshall through cannulation and injection of alcohol. The ligament of Marshall it's a remnant of the left superior vena cava and runs along the posterolateral left atrium, and it has been implicated as potentially involved in both focal and reentrant drivers of atrial fibrillation. So clearly the ablation strategies for atrial fibrillation have evolved over time. The cornerstone really is now pulmonary vein isolation, and we're still looking to demonstrate very good benefit in terms of adding on to that in other contexts. And hopefully some of the ongoing research will show what strategies we can use to be effective in that regard. Beyond the technique and technology of atrial fibrillation ablation, there's other opportunities for improving how we deliver care for atrial fibrillation ablation patients. We developed a project looking to improve the standardization and efficiency of periprocedural management for atrial fibrillation ablation patients, with an eye towards, of course, maintaining safety in this population as well. We first assessed the current group practice over a 6-month period, including all atrial fibrillation ablation cases that were performed on an outpatient basis. There were only really a couple that were performed as an inpatient. We performed a review of literature and identified several areas in which we could potentially target for standardization or improving efficiency of the procedure. These included periprocedural anticoagulation, use of Foley catheters, use of a figure-of-8 suture for hemostasis, and same-day discharge. We then undertook a group survey and discussion within the EP group to find an agreeable practice standard. We introduced a standardized bundle of features that included a short duration of interrupted anticoagulation prior to the procedure, with early reintroduction of anticoagulation post-procedure, we agreed on a lack of routine use of Foley, so only in specialized circumstances would we insert a Foley up front. There was routine use of the figure-of-8 suture amongst most of the operators. There was one operator that preferred to continue with manual pressure. And we introduced a protocol for early ambulation. We also pursued a default approach of same-day discharge following certain criteria. And we had a standardized post-op protocol of sort of 1-3-5. So bed rest for 1 hour post-operatively with the suture in place, and then allowing what we call bedside mobilization, so the patient could sit up, go to the bathroom, that sort of thing. Resumption of anticoagulation at 3 hours post-operatively, and then the suture was removed 5 hours post-operatively if it was present, followed by a 30-minute period of bed rest. If there was no suture, then a 4-hour bed rest was maintained. We sought to capture some of the relevant information that related to these different interventions using a standardized SMART phrase, one that was used by the nurses during perioperative care, and one used by the operating physicians intraprocedurally in order to ensure that we had uniform capture of information. These are the criteria that we used for same-day discharge and conversion to overnight stay for patients who were identified for potential same-day discharge. This was developed in collaboration and discussion with the members of the anesthesia team, as well as a review of the literature that was available relating to same-day discharge in the context of atrial fibrillation ablation. This is some of the information that we have relating to prior to our introduction of the AF bundle. The same-day discharge rate was about 47%, but as you can see, significant variability amongst different operators in the group. This is our information after the introduction of the bundle. So of relevance, we had a 6-month period for the pre-bundle group and a 5-month period after the bundle was introduced. We found the rates of same-day discharge improved to 66%. This was significant, as I'll show on a figure on the next slide. And we had about 21% of the patients, so about 1/5 who were planned for an overnight stay up front because they met some of the criteria that I had shown, and 12% of patients who were converted from a planned same-day discharge to an overnight stay. As you can see, there was still some variability amongst different operators, but there was uniformly an increase in the propensity for same-day discharge across the group, except for one who was maintained around 80%. And I'll say it's different. The operator numbers are different on this versus the previous slide. So our comparison between prior to the bundle versus following the bundle did show a significant difference in terms of the number of same-day discharges. Some of the more interesting information that we found from this as well was what were the reasons that patients ended up staying overnight. For those who were planned for an overnight stay, the majority were related to either patient preference or a far distance from the hospital. Patient preference could be related to a number of different factors, including if they were a redo atrial fibrillation procedure, they may have stayed overnight previously, and so were interested in following the same experiences they had before. And those who stayed more than an hour away from the hospital, there were a few who were not included in that group who were from a far distance but had other accommodations arranged, whether it was staying at a hotel or staying at nearby family or friends as well. So this was only those who didn't have other arrangements made. It raises some questions for opportunities for potentially improving our rates of same-day discharge in terms of looking at each of these groups. Could we, for example, offer accommodation at the residence here? If that was less expensive than an overnight stay in hospital, then that might improve our bed availability and same-day discharge rates. As far as patient preference, education around the safety of same-day discharge, as well as just experience with it, will likely result in a reduction in the number of patients who request to stay overnight. Also, of course, there's the practical impacts of the COVID context, which have led to more hesitancy in staying overnight, so that might also play a role. Of those who were planned for same-day discharge but were converted to an overnight stay, the majority were related again to a combination of patient preference and a prolonged procedure duration. We'd set a cutoff of 5 hours for a length of procedure which would result in a conversion to an overnight stay. This is based in large part to previously published literature on that. It's a relatively arbitrary cutoff, so you could raise the question of if it's even necessary to have that. If someone's being the first case in the morning, that still may give an adequate amount of time for recovery, but that's something that can be looked into. Importantly, only 3 complications occurred that resulted in an overnight stay, and there were 3 post-anesthesia concerns. These were primarily related to obstructive sleep apnea in the context of having received general anesthesia. It is important to mention that all atrial fibrillation ablations that were performed in each of these groups were performed with general anesthesia. There are centers that perform these procedures under conscious sedation as well, but none of the patients included in this had it performed under conscious sedation. So in terms of looking at our complication rates and the utilization of healthcare resources, including the emergency department and calls to our nursing coordinators. So the total complication rate was 2.2%. There was one perforation that occurred that necessitated placement of a pericardial drain and a short hospital stay. There was one stroke that occurred 2 days after the atrial fibrillation ablation, and there was one pseudoaneurysm that was managed with thrombin injection. There were 11 patients that presented to the emergency department or through calls to the nursing coordinator were seen in person at the Heart Institute within a week of the ablation. Within the same-day discharge group, there were 4 patients who developed pericarditis, 3 within 24 hours, 3 within 24 hours, one of whom developed pericarditis 3 days later and then presented to the emergency room. 2 patients who presented due to urinary retention, one with a minor femoral bleed 3 days post-operatively, one because of leg edema, one relating to a nerve praxia that was attributed to the to a hematoma resulting from the procedure. 2 of these patients were admitted, both of whom had pericarditis, and the remainder were managed as an outpatient. In looking at the cases, 4 of them could potentially have been avoided with an overnight stay, but there were no no serious complications seen as a result of discharge and outpatient management of these issues. Within the non-same-day discharge group, there were 2 patients that presented to the emergency room. One related to management of their Foley catheter. They had stayed overnight as a result of urinary retention and had a Foley catheter placed, and then came to the emergency room because of issues with managing it. And one patient who had swelling at the site of our arterial line, a radial arterial line that had been placed for hemodynamic monitoring. There were 10 other calls that were made to the nursing coordinator that were evenly distributed between groups, which were managed just over the phone. So these were minor issues that either required just reassurance for the most part, or in a couple of cases, a prescription by phone. So the figure of 8 suture, for those who aren't familiar with it, this is a technique that involves placing a suture just prior to removal of the cannula. In placing this suture, it provides, it essentially is placing moderate pressure at the site of access so long as the suture remains taut. There are a few different ways that this can be done. One that's become sort of the most prevalent is the use of a 3-way stopcock in order to maintain tautness of the suture. This has a nice advantage in that if there is bleeding at the site that occurs either at the time of suture removal, or if there's an issue with placement of the suture, you can always loosen it and then tighten it again back onto it prior to removing the suture. There are a few limitations on comparisons between this group. Namely, we didn't have uniform uptake in terms of using the figure of 8 suture. For the most part, though, when it was used successfully. There were just a couple of occasions in which the figure of 8 suture was not used when it was intended to be used. Those included one situation where the suture broke while it was being tied. One case where arterial access had to be provided femorally, and so in that case, manual pressure was applied in lieu of the suture. And then third, it wasn't clear why the suture was not used in that case. When looking at a time that nurses had spent holding pressure at the site, there was a reduction in the average time that was spent holding pressure at the site. Although this was very minor differences, an average of 1.2 minutes versus 3.5 minutes holding pressure at the site of vascular access, and there was no significant difference in terms of significant hematoma risk. Foley catheters were not used routinely, but we did find that close to 9% of patients still had insertion of a urinary catheter at some point in the perioperative period. There was one patient who had it planned up front, and this was because of a anticipated prolonged procedure, as well as a history of heart failure following ablation. And so there was a plan to deliver Lasix. 7 patients had either in and out catheterization or placement of a temporary catheter for a short period of time, and that ended up having no impact on their stay in hospital. One did require placement of a Foley catheter that resulted in overnight stay with successful trial avoid the next day. Another one who failed the subsequent trial avoid and so had to be discharged home with the catheter with follow-up with urology. And then, as were mentioned, there were 2 patients who presented the following day to the emergency department with urinary retention. And both of these had been same-day discharge cases. So I think that this is useful information, because I think that this is an opportunity for potential improvement within our atrial fibrillation ablation population. Interestingly, urinary complications are not something that have really been captured in some of the other literature in the area, in part just because it wasn't identified upfront as something to be looked at. And I think that's largely a function of the retrospective nature of a lot of the previous analyses. The existing literature is supportive of safety of same-day discharge, but it has the important limitation of being largely retrospective in nature. There was a very large cohort in British Columbia that was looked at, in which they found no difference in composite hard outcomes 30 days post-operatively. Although they did find that there was higher rates in those who ended up requiring overnight admission as a result of complications. As I was mentioning, I think that the major limitations of some of these studies is that they looked back at the procedures and looked at who was discharged the same day and who ended up staying overnight, rather than identifying the patients up front, looking at reasons why patients were planned for overnight stays versus needing to be converted. And then a result of us prospectively looking at this information allowed us to capture something that may not have otherwise been identified. So some of the main takeaways from this information includes the successful and safe increase in same-day discharge volumes, identifying the most common reasons for planned overnight stays and reasons for conversion from planned same-day discharge to overnight stays being potential targets for improvement in our delivery of peri-ablation care. Introduction of the figure of 8 suture is significant in terms of saving time, holding pressure. It takes only a minute to place versus longer duration holding pressure at the site of access. There may be some benefits in terms of demand on nursing care post-operatively as well, although that doesn't seem to be overly significant. And then I think that one of the important features is the urinary retention as a not infrequent issue perioperatively. And so there may be opportunities here for us to identify patients who are at risk for this upfront and collaborate with urology, both in terms of identifying are there ways that we can minimize this risk, and can we have a pathway for management of these patients if it's a frequent occurrence, so that we can improve our experience in this regard. So in conclusion, atrial fibrillation is a commonly experienced cardiac problem with significant impacts both on health and quality of life. Improvements in our mechanistic understanding as well as technology and skills all can contribute to incremental improvements in terms of outcomes. And additionally, there are opportunities to improve our delivery of care through careful examination of our processes and implementation of efficiencies. Thank you for your attention, and I'd be happy to entertain any questions.
Evan, thank you very much. That was an excellent overview, and nice to see some of the quality improvement projects that your team has been working on. Could you comment a little bit on what techniques are utilized here at the Heart Institute? Are we doing any cryoablation now, or is it all RF?
So the majority are RF, but there is some cryoablation that's done as well. One of the main or an influencing factor is the fact that a lot of the studies that we've been involved with have been primarily RF. So if patients are enrolled in one of those studies, then they by necessity have to undergo radiofrequency ablation. But even independent of the study population, the vast majority are radiofrequency ablation as opposed to cryoablation.
And is that a cost issue, an operator preference issue, a modality success issue? Like what's the rationale behind the decision making there?
It's a combination of factors contribute to it. I do think one of the most important ones is the operator preference. There are some significant advantages to RF ablation in that there's less utilization of fluoroscopy. There's an opportunity for obtaining a good voltage map, which can provide important prognostic information as well. It gives you the ability to be a bit more flexible in terms of the ablation that you perform. With cryoablation, you essentially need to just kind of go for isolating the pulmonary veins, and if there was some other target of interest, you couldn't perform that ablation, whereas radiofrequency ablation provides that opportunity. One of the major advantages of cryoablation had been the procedure duration. It could be done significantly quicker. With the advent of high power, short duration, this is even the playing field a little bit, as it's made our RF procedures significantly faster. Another important feature is the availability of cardiac anesthesia. We have really great cardiac anesthesia support here, which facilitates the use of general anesthesia for RF ablation, which is really critical for catheter stability. For cryoablation, it's a bit less critical because the freeze results in adherence to the tissue, so there's less of a challenge in terms of maintaining stability as a result of patient factors.
Could you comment on, and I know it's a mixed population, so perhaps not entirely fair to compare, but the quoted success rate that you give to patients. So, someone comes in for a consult for AFib, and you explain the procedure. What's the success rate that you quote them, and how are you defining success when you explain it to patients?
So it's very patient. It is, as you're sort of alluding to, it is very patient specific. It depends on the phenotype of atrial fibrillation, other patient-related factors as well. The amount of substrate that we might expect as a result of comorbidities, etc. The success rate that's going to be quoted is then generally we quote sort of in the 50 to 60% range for persistent atrial fibrillation and 70 to 80% for paroxysmal, with the caveats that it may require a second procedure in order to identify areas that need to be touched up. And we explained that this success is freedom from atrial fibrillation out to 1 to 2 years, really. Now I've started to also include, I say I, but really multiple people have started to include the information relating to the significant reductions that we see in atrial fibrillation burden as well. And so even if we may not achieve, that what we consider to be success using that standard in terms of saying 70 to 80% success rates, we still may be achieving success that's relevant to the patient in the sense of a reduction in symptom burden, a reduction in hospital visits and emergency department visits, and also potentially avoiding the use of antiarrhythmics, which many patients are not keen on. So it's really ends up being multiple factors, and I think that it's important to relate it to a patient's context and their individual goals as well. If they want reduction in symptom burden, I think that ablation is a very attractive option.
Excellent. I think Dr. Golian has a couple comments.
Yeah, no, good presentation, Evan. A few quick things in terms of cryo and RF. Locally we're expert. We have the expertise in both cryo and the RF, and it does come down to patient decision. But we're really good at what we've been doing, which is RF ablation. Our results are actually better than what's reported in Fire and Ice. You know, at 66% was what their results were. We typically code for paroxysmals likely around 80% success rate. And it's the same thing with if you look at preliminary results from COAST, you know, our persistent AFib ablations, they actually do better than what's reported in the literature. And this is with intensive monitoring afterwards. You know, we do routine monitoring at 3 months, 6 months, 12 months with 2-week Holter monitors, which is what's lacking from the other studies. And, you know, we're looking into using ILRs for continuous monitoring for our future studies, which is going to give us a little bit more information in terms of arrhythmia burden, which we think is really what's driving symptoms as well as the morbidity for these patients. Just to put things in context about the Foley thing, you know, prior to trying to standardize the Foley catheter use, we were routinely using Foleys for almost all comers for arrhythmia just because they were getting intubated. You know, our use was around 80%, with that group of patients having, you know, 3 to 5% of them ended up with urosepsis, another 30% of them ended up with hematuria, and you know, we still had about 10% urinary retention despite the, you know, routine use of Foley. So we decided to stop using it. And I think it's you know, the point of, if you don't keep track of these things, unfortunately, you don't know where the issues are. And I think Evan nicely alluded to it. You know, if you don't have numbers, you won't be able to actually improve on anything. And, you know, thanks again, Evan, for doing all these things. The last 2 years have been fantastic working with you. You know, very enthusiastic, works very hard, and it's been a pleasure, you know, working with you.
Thank you. Likewise.
All right. Well, thank you very much, Evan. That was an excellent presentation and brought us up to date on what we're doing. This will be a nice segue to next week's Grand Rounds. We have Dr. Steffel from Zurich joining us, who will be giving a presentation with our Dr. Nair, comparing and contrasting this CCS from the ESC AFib guidelines. So this will be a very nice bridge to that. Next week is a Grand Rounds presentation, which means that you will need to register for it. Research Services will send out the invite later this week. Thank you very much for joining today, and we'll see you next week.